Hi, everyone. My name is Anita Kelkar. I'm a first-year cardiology fellow from Emory. I'm lucky to interview Dr. Peter Wilson, who's also from Emory University as well. Dr. Wilson, just wanted to start off. What are your thoughts about the current guidelines, particularly in regards to risk estimation?
Sure. So the 2013 American ACC-AHA guidelines was a joint effort. Originally started out with NHLBI, and then it became the ACC-AHA. They're getting, I guess, their trial period, so to speak. Guidelines don't ever really get a trial, but it's like a ball. It goes back and forth over a net. Do you like them? Do you not like them? What is the next step? I think one of the first things is Dr. Stone and others who've been involved with American guidelines likely to try to put together an update in the next couple of years. I don't know how long that would take, but that's number one. Number two is there's been a lot of concern about the risk estimation modules that are used in the guidelines. There were papers, about one every 3 to 6 months now, and commentaries about it. And there are some who like it, of course. I was on the guideline committee, so I'm conflicted. But it's also a growing area of research, so to speak. So the first one is a lot of the American estimates are based on 1970 to 2000 type of experience. And here we are in 2015. You'd like to get more contemporary experience. So that's one of the, I think, challenges that we have. Some of those who have been criticizing the guidelines have more recent data. So there's going to be differences. In fact, we're doing a lot better for cardiovascular risk reduction in the last 15 years. And in preventive cardiology, we want to think it's care or what we do in the clinic, and that's part of it. But there's also there's secular changes in the community. About the only thing we're doing poorly is obesity and the development of diabetes. But in fact, we're doing better than we were 20 years ago for blood pressure treatment and for lipid treatment. When I was in training, like you, we didn't have blockbuster drugs. We didn't have everybody who was obese getting ACEs and ARBs. We didn't have any statins. So that's having a dent. So for sure, there's that element of what we do in the clinic. But some of the risk estimations, we're going to need more contemporary data, I think. That's where we're going.
What do you think about risk estimation in women, particularly?
That's a hot topic.
I know.
And we have a colleague, Dr. Wenger, who feels real strongly. So women get heart disease a little later. Remember, there's a 10-year protection. That's number one. They have smaller coronary arteries. So once they get their coronary disease, they do not do as well. I think it's gotten swept a little bit under the rug, but historically, women are more likely their first event is angina or something that's hard to label. I think we now call it something hard to label, but they do not get a severe coronary event right away, and sudden cardiac death is really, really uncommon in women. And so we have investigators who are our colleagues who are very interested in this, but it's tough. You know, what do you do? And you have all these women who you just can't pin down. And we all have conferences on Takasubos and all these other types of unusual things. But women are probably getting ischemic disease, which is not exactly the same as men.